I want to welcome everyone to tonight's information lecture on atrial fibrillation. If you're here for any other reason, you're in the wrong room. But atrial fibrillation, we're going to talk about what it is. We're going to talk about the causes. We're going to talk about the heart itself and why people have atrial fibrillation, what the different parts of atrial fibrillation, different timing of atrial fibrillation, and hopefully answer all your questions. So if you have questions, feel free to write them down. I'll be happy to answer all the questions that you have at the end of the lecture, or making it more informal, we can answer some along as we go. First off, a little anatomy question. I'm in a little anatomy course. This is going to be brief. So the heart has 4 chambers, and 2 of these are carrying blue blood, 2 of these are carrying red blood. The red blood is oxygenated blood, the blue blood is deoxygenated blood. The blood comes from the body, from the inferior vena cava up into the right atrium, and from the superior vena cava into the right atrium, so it collects in the right atrium. The right atrium then squeezes and pumps the blood into the right ventricle. The right ventricle squeezes and then pumps the blood out to the lungs, and then it comes back to the left side into the 4 pulmonary veins that fill up the left atrium, that then pumps it into the left ventricle, and then the left ventricle, it pumps it out, the oxygenated blood, to the entire body. So basically you have 2 pumps in parallel and 2 pumps in series. The top 2 chambers squeeze at the same time, and the bottom 2 chambers squeeze at the same time. So it's very uniform, once every second, billions of times in your life. So the top chamber squeeze, the bottom chamber squeeze. What happens with atrial fibrillation is you get a chaotic contraction of the upper chambers. Rather than squeezing at 60 times per minute, they go at about 600 times a minute. So they're just quivering up there. They're not squeezing, they're not pumping the blood forward. And therefore, from the sinus node, and that's where the pumping starts, God-given sinus node causes both the upper chambers to squeeze at the same time. And when that fails, then you have fibrillation, or that quivering of the top 2 chambers. Normal, the sinus node fires, gives it to a backup pacemaker called the AV node. The AV node then holds that charge for 0.2 of a second and then fires it down into the bundles. And you have a left bundle squeezing the left ventricle, and you have a right bundle squeezing the right bundle. And again, these are occurring simultaneously. As these 2 chambers squeeze, 0.2 of a second later, the bottom 2 chambers squeeze. So, atrial fibrillation is often a rapid, irregular heartbeat of the upper chambers, which then causes the bottom chambers to become irregular as well. And as the bottom becomes irregular, you don't get that cardiac output, you don't get the forward flow of blood, people get dizzy, people have palpitations or irregular heartbeats, they can get short of breath, they can even pass out. And typically the lower chambers are going to run at around 110 to 140. Rarely over 160 or 170, but usually around 130, 140 you'll be seen, unless they're on medications or unless they have other reasons for their atrial fibrillation. So, according to our chart here, hopefully you guys have had a little time to read it. Paroxysmal atrial fibrillation, that means that you have palpitations, they're brief, they last less than a day. Typically, they will go away on their own. There are ways you can get rid of them by bearing down, like you're having a bowel movement, or splashing cold water in your face can sometimes get rid of them as well. But typically paroxysmal, or the first episodes of atrial fibrillation, are very brief, very short-lived, and they go away spontaneously without having to take medication or without having to do anything to the heart, such as shock it. Next, atrial fibrillation begets atrial fibrillation. What do I mean by that? Once you have atrial fibrillation, you're at higher risk to get atrial fibrillation again. And the more you get it, the more likely you're going to have it again. So it gets worse and worse and worse with time. until it becomes chronic atrial fibrillation. But persistent atrial fibrillation is one that lasts more than a week. You'll need to change it somehow. You'll either need to shock the person back into a normal rhythm or give medication to get them back into a normal rhythm. You don't want to do that without first making sure that they're on blood thinners, because there is a risk of what we call thromboembolism or blood clots. And typically when you have blood clots from atrial fibrillation, if it's in the left atrium, 80 to 90% of the time it'll go to the brain and cause a stroke. And that's the big problem with atrial fibrillation, is that it does increase your risk of strokes. So persistent atrial fibrillation lasts more than a week, or you've gone to the doctor and he has to shock you out of it, or he has to give you medication to get you out of it. Permanent atrial fibrillation. That is when you have had it chronically. You have not had any way to get you out of it. The shocking has worked for a day, but then you went back into it, or the shocking didn't work at all to try and get you out of the atrial fibrillation, or the medication did not work. And a lot of people don't want their heart shocked. I mean, a lot of people, are afraid to have, electrical currents run through their body. I mean, I touched a hot wire fence when I was a young kid. I don't want to touch it again. I understand. But frequently we do shock the heart back into a normal rhythm, and it can stay in there. If it stays in for more than 2 years, then we say that that's a success, and we've kept them out of atrial fibrillation for at least 2 years, and then we continue with our treatments. If it doesn't last 2 years, then we start looking at other avenues or other treatment plans, and we'll talk about those in a moment. Of course, this does not pertain to the other causes that are reversible causes of atrial fibrillation, such as thyroid problems. A very high thyroid storm, or during surgery, you can, especially thyroid surgery, you can have people have atrial fibrillation. After open heart surgery, about 10% of the people will go into atrial fibrillation just from the doctors manipulating the heart during the time of surgery. They'll go into atrial fibrillation afterwards, but typically that's short-lived. Electrolyte imbalance. If your potassium's way off or your magnesium's way off, sometimes that'll put you into atrial fibrillation. And by reversing that, then your atrial fibrillation goes away and you never have it again. Or obviously, people found on the street that have had a few too many bottles, and we'll go into that acute and chronic ethanol intoxication, or drinking too much. So about the heart itself, what is the pathophysiology, or what is the causes? Where does this start? And again, I pointed out over here the pulmonary veins. There are 4 pulmonary veins that come from the lungs, oxygenated blood, into the left atrium. 2 from the right lung, 2 from the left lung, and they come into the right atrium. These, we have found, are the areas where little wavelets, little extra beats start, and then they go through the entire atrium in combating the normal sinus node. So they start with little waves around here and here that if those take over, then the sinus node can't keep up, or it can't compete, and the little fibrillatory waves, which go at about 600 beats a minute, will take over, and this entire thing, even though this is firing, the whole thing is fibrillating, or squeezing, quivering rather than squeezing. So multiple wavelets, or small little wave fronts, come out of the pulmonary arteries into the left atrium. The God-given pacemaker is in the right atrium. Atrial fibrillation is strongly associated with some other risk factors. In other words, some people, the older we get, the more likely we're going to have atrial fibrillation. Hemodynamic stress, such as mitral stenosis or tricuspid valve stenosis, mitral regurgitation or tricuspid valve regurgitation. These all put pressure back up into the atrium, higher pressure than normal. The atrium are a thin-walled, as I tried to draw here, the atrium are a thin-walled chamber, whereas the ventricles are a thicker-walled chamber. So if the atrium are a thin-walled chamber, a little bit of pressure can stretch them out like an old rubber band. And as they stretch out, then the likelihood of them fibrillating is higher. So you want your atrium to be small. You want your atrium to be less than 4 centimeters each, hopefully down around 3 centimeters. But we can check that with an echocardiogram or ultrasound of the heart. Secondly, atrial ischemia or myocardial ischemia. Ischemia means that your heart is not getting enough blood supply, such as coronary artery disease. People frequently get angina when they don't have enough oxygen going to their heart. That's chest pain, typically in the middle of the chest, sometimes going up to the left shoulder. Angina pectoris, the pectoralis muscle is the chest muscle right here, and typically it's on the left side. It doesn't have to always be on the left side. Typically it's retrosternal, in other words, behind the breastbone, but you don't even have to have chest pain to have ischemia. Now, ischemia means not enough oxygen or not enough blood supply getting to the heart. If the atrium become ischemic, then they're more likely to go into fibrillation. So that will increase your risk of fibrillation. So coronary artery disease by itself can cause atrial fibrillation. Inflammation. People can have inflammation from a virus or from unknown factors of the sac around the heart called pericarditis. You can have inflammation of the muscle itself called myocarditis. And that is just an inflammatory response. If it's in a bursa, it's called bursitis. If it's in a joint, it's called arthritis. In the heart, it's either called myocarditis or pericarditis. Pericarditis is the sac around the heart. Myocarditis is inflammation of the heart itself. What else can cause it? The lungs. The lungs in the heart. The lungs surround the heart. And the lungs in the heart play an important role hemodynamically together. As the heart pumps out to the lungs and the lungs drain back into the heart, that hemodynamic process, in other words, that continuous blood flow, will change the dynamics of how the heart has to work, how hard it has to work. And the harder the heart has to work, the more likely it's going to go into atrial fibrillation. Pulmonary embolus, and that's where you get a blood clot in the lungs, can increase your risk of atrial fibrillation. Pneumonia frequently can increase your risk of atrial fibrillation or lung cancers. Next one we talked about a little bit, alcohol and drug use. Cocaine is pretty classic for having young kids go into atrial fibrillation, and they certainly come in with all kinds of chaotic rhythms, not just atrial fibrillation, but even worse fibrillations such as the heart ventricles, and those are the big pumping chambers, and that can cause sudden death. And that happens frequently in cocaine use. Chronic alcohol use also does the same thing. It increases your risk of atrial fibrillation and can increase your risk of a cardiomyopathy and sudden death from ventricular fibrillation as well. Hyperthyroidism or other endocrine orders, diabetes mellitus. A lot of people have diabetes here in the United States. We also have a high incidence of atrial fibrillation, so they are correlated. Pheochromocytoma, that's a small little tumor, usually in the gut. It's only about a half a centimeter, which is about a quarter of an inch, or smaller, eighth of an inch. And it sits in the gut and it produces endocrine outlets. So it causes epinephrine or some of the other excitability things, the fight or flight adrenaline hormone, and it'll just secrete it automatically. It's not supposed to. It's not supposed to be there. It's a tumor. But sometimes people, it's rare though. So no one in this room probably has one. Maybe a few people have heard of one. So it is very rare. But hyperthyroidism is quite common and diabetes is quite common. So you do have to be aware of those. Neurological disorders. TIAs or strokes can increase your risk of atrial fibrillation, but also sleep apnea, hypoventilation syndrome. People like me with the big bellies and the thick necks, they and don't breathe for a while, then yeah, that increases because that causes hypoxia. That decreases the oxygen going to the heart, so that causes the ischemia that we talked about, and that increases your risk of atrial fibrillation. And of course, congenital heart disease. People are born misaligned, and even after the surgeon tries to put them back together every way they can, those people with congenital heart disease are going to be at increased risk for atrial fibrillation. And advancing age. No one in here, mind you, but advancing age is a strong independent factor of who's going to have atrial fibrillation. The older you get, the more likely you're going to have atrial fibrillation. So what are the common causes of atrial fibrillation? Basically, the four that you really have to worry about is high blood pressure, coronary artery disease or heart disease, hyperthyroidism, and excessive alcohol. So some of these you can change, some of these you need medical or surgical treatment for, but these are the big four that cause atrial fibrillation. So how does the doctor find out that you have atrial fibrillation? The doctor in the emergency room will do a history and physical, initial evaluation to determine whether or not you're stable. If you are not stable, if your heart is going so fast that you don't have much of a blood pressure, you can't respond to the emergency room doctor, you can't think, you're barely breathing, he's going to shock your heart and he's going to bring you back into a normal rhythm. Up to 90% of the atrial fibrillations may not cause symptoms, but some are very severe and do need emergent treatment. But what are some of the symptoms that people get? The doctor will ask you, do you have palpitations? Do you have shortness of breath? Do you have dizziness or fatigue? Do you have chest pains? And do you have swelling of your ankles, increasing in your jugular veins here in the neck? Can you not take a deep breath because your lungs are full of fluid? So he'll be asking those. And what are the other precipitating factors? Like we talked about already, previous history of heart disease, previous history of atrial fibrillation. Any questions so far? Okay. Then the doctor goes in and examines the patient, assuming that they are stable. Then we check the heart rate, check the respiratory rate, and we do all the things, typically in the emergency room in the beginning, and then the cardiologist will do the same thing over again. And basically try and figure out, is rate control or cardioversion or treatment immediately for atrial fibrillation needed, or can we just start with medications to help the person with atrial fibrillation? Typically, as I said, the heart rate is between 110 and 140 beats per minute. Normal is between 60 and 100 at rest. So if this person's at rest and his heart rate's coming in at 130, they're not feeling good. They're having the irregular heartbeat, and they might be a little sweaty. They might be short of breath. So we do have to evaluate them that. And then obviously it gives us what the future is going to hold. Is this guy going to go downhill fast? Is he going to need something, or this gal not going to do well through the night? And you have to know that from the emergency room up to the intensive care unit or floor, wherever you happen to go. Nowadays, sometimes people do go right home from the emergency room with atrial fibrillation. And if their heart rate is controlled and they're put on blood thinners, then that's all right to go home right from the emergency room in atrial fibrillation. And that is now our current treatment for just lone atrial fibrillation or atrial fibrillation that doesn't cause any other sequelae or problems. So the diagnosis of atrial fibrillation is also done by an EKG, and doctors read EKGs all the time. You have an irregular complex, a narrow complex on the EKG, and I'll show you an example in just a moment. There are no P waves. The QRS pattern, again, starting with my diagram here, this sinus node and the contraction of both the atrium form a P wave. The electrical impulse then goes down into the ventricles, and you get what we call a QRS complex. So that is just terms that we use to determine whether all the parts of the heart are working. So this is the EKG, and I can tell that this EKG is running fast. He is running about 130 beats per minute. He or she does not have discernible P waves. I see, a bottom line that's just kind of wavy, and that's the bottom line right here. Are those P waves are going at 600. If you actually had calipers or measuring tools for EKG, you could measure them out at about 600 beats per minute. And the top, the QRSs, the spikes, are going at about 130 beats per minute. And this person has atrial fibrillation. What else is the doctor going to do? He's going to do some lab work. He's going to check for infection. He's going to check for anemia. He's going to check for thyroid functions. He's going to check for coronary artery disease. You might get a troponin, which is a check to see if you're having a heart attack. And that'll all be done in the emergency room. An ultrasound is frequently done, whether it's done in the emergency room or up on the floor. An ultrasound is going to look at the valves of the heart. It's going to look at the size of the heart, whether the heart is enlarged, because enlarged hearts go into atrial fibrillation more often than small normal hearts. And you're also going to look for that sac around the heart called the pericardium. And if that's diseased, that increases the risk of atrial fibrillation. And if you think that the blood clot has gone to the lungs, and that's why they're really short of breath and they're in atrial fibrillation, frequently you'll get a CAT scan of the lungs to see if there is a blood clot in the lungs. And that frequently is a cause of atrial fibrillation. Yeah?
I had pulmonary embolism.
Yep.
And I know I'm AFib.
Okay. That pulmonary embolism is actually could have been the strain on the heart that you had that put you into atrial fibrillation.
I was wearing a CPAP that night.
Mm-hmm.
The doctor said, had I not been wearing it, there's a possibility it would not be around.
My cousin's daughter was 19 years old when she fell at a bowling alley, and she died from a pulmonary embolism. So, yeah, it happens all the time. So if you do get swelling in your calves, swelling in your thighs, redness in your thighs or your calves, or if it hurts to flex or bend, go see your doctor. Make sure that you're aware of what is going on, because people die from pulmonary embolism all the time. And they normally die, unfortunately, within the first hour. So if you think you have a blood clot, go to see your family doctor. If you become suddenly short of breath, immediately go to the emergency room. Okay? And of course, chest x-ray, yeah.
Now, when you do have a blood clot, it will be red. You have redness.
Typically, it'll have redness. Many of the times, the blood clots are from the big vessels or deep vessels in the legs. If the blood clot is actually below the knee, it's probably pretty safe. It's not going to cause a big enough blood clot to kill you. But a lot of times, these are coming from the thighs or even the pelvis. And the pelvic veins and the thighs are the most common cause of the lethal pulmonary embolus. So it's a big blood clot that'll go either to one lung or actually even both lungs. So, but yeah, typically the legs will be red, sore, and difficult to move. So if you're going up and down and it hurts in your calves and you've not been working all day long, then be aware. And of course, chest x-ray for heart failure or pneumonia, because those are also causes of atrial fibrillation. So how do we treat atrial fibrillation? What's the most important thing that we do is to make sure people don't have strokes, or make sure these blood clots that are in the heart don't go elsewhere, such as to the bowel, to the kidneys. But again, 80 to 90% of the time they go to the brain, and strokes are devastating, physically, mentally, emotionally, every way you can name, financially. I mean, strokes are bad. But basically, the cornerstone of treatment is to get the heart rate under control, and you want it down below 110 typically. We used to try and get people down below 80. Now we're kind of accepting anything below 110 if they remain in atrial fibrillation. But we still are trying, normal again is between 60 and 100 at rest. So we're trying to get it down to at least 110. And frequently when we do get the heart rate down, the people will spontaneously go back into a normal rhythm just by lowering the heart rate. So if the atrial fibrillation isn't treated, it'll just keep puttering along at 110, 120, 130 beats a minute, and the people don't feel good and they're not doing anything, so they just lay there and they stay at home, and that's not the right thing to do. If you feel your heart going at 130, 140, you need to go see the doctor to get yourself checked out. But the most important part is not having a stroke. And typically the first treatment we start off with in the hospital is heparin or low molecular weight heparin called Lovenox. We basically want to thin out the blood so that you don't have a stroke. And once you started that, then we can start the longer term anticoagulants such as warfarin or Coumadin, the old rat poison. I'm sure you guys have all heard of that. Decon has been using this stuff, but we use it therapeutically in lower doses to keep people from having blood clots that go to their brain, keep them from having strokes. And that's the biggest issue with atrial fibrillation. Several risk factors for the anticoagulation decision is from the CHADS-2 VAS score. And the CHADS VAS score or the CHADS-2 VAS score is a way that we determine what is the best treatment for you. And the CHADS VAS score are basically, are you in heart failure? Do you have heart failure? There's a point for that. Do you have high blood pressure? There's a point for that. Are you over 75 years of age? There's a point for that. Diabetes? There's a point for that. Or stroke or prior TIA? There's 2 points for that. So then you figure out your risk, you add up your points, that'll give us an idea of what your risk of having a stroke with atrial fibrillation is. And if your CHADS VAS score is 0, then you might just use aspirin. If your risk is low, if you're a young person with atrial fibrillation and don't have any other diseases, we used to call this lone atrial fibrillation, now we call it a CHADS 0, then maybe aspirin is all right. If it's intermediate, then you have to talk with your doctor and talk about what is going to be the best thing for you. Are you approaching 65 where you're going to add another point? And we'll go into the CHADS-2 VAS-2 score, which is a better way to determine what the risk of a stroke is in just a moment. High CHADS risk score, people should be on anticoagulation, whether it's warfarin, Coumadin, or one of the newer agents. And there's 4 newer agents, such as the brand names are Eliquis, Pradaxa, Xarelto, and Savesa. So there are 4 new ones out there on the market that are competing for the warfarin market. They have good benefits and bad benefits depending a lot on your insurance. So the American College of Cardiology and the American Heart Association have actually deemed a better calculator. It's called the CHADS-2 VAS-2 score. And what they add up is very similar things. Congestive heart failure, hypertension, diabetes, vascular disease, including plaquing of the aorta, if you've had an ultrasound of your aorta, or carotid ultrasound and you have plaquing in the carotids, we know that you're at risk. Then 65 to 74 years of age is 1 point, but if you're over 75, you get 2 points. So the scoring difference, scoring is a little different, and you get a total of 9 points on this potentially. And the evidence indicates that aspirin probably is not as good as we thought it was back when we just had the CHADS score. Aspirin is good for prevention of heart attacks. And don't let anyone dissuade you if you're trying to prevent a heart attack. Aspirin is good to prevent heart attacks, but the arteries of the neck are bigger vessels. The heart causing atrial fibrillation causing a stroke is a different kind of animal. It's not like the coronary artery disease and the platelets in the coronary arteries that cause a heart attack. So we're really treating the same disease, different parts of the body, but also different size vessels. So aspirin may be helpful for heart disease, but maybe not atrial fibrillation and stroke. So frequently we use the anticoagulants that I just mentioned, the 4 new ones, or warfarin. And warfarin is still the old standby. RF catheter ablation or radiofrequency catheter ablation, they actually have a pacemaker wire that goes up through your arm or up through your leg, up to the area of the heart, going back out to these pulmonary veins. They go up into your right atrium, over into your left atrium. They find these 4 different veins and zap them. It's not as strong as a microwave. It's a radio frequency wave. It's the same wave coming out of the radio towers that are around us all the time. You cannot put your transistor radio up to your chest and do any good. But it is the same idea because they bring those radio frequency waves right up close to the pulmonary veins, and they burn little areas to convince the heart not to give those little wavelets, those little starters of the atrial fibrillation. Management of rate control. Typically we use beta blockers, calcium channel blockers. We use digoxin still, especially in people that are sedentary, aren't mobile. Digoxin doesn't, digitalis, digoxin, or foxglove, I don't know what you've heard in the past, but it does still slow down the heart, but if you're active, it's not going to be very good at slowing down the heart. Your heart's going to speed up very rapid. Beta blockers and calcium channel blockers are normally the first-line agents for trying to control heart rate. And different beta blockers and different calcium channel blockers will control that heart rate better or worse. But talk to your doctor about which one is best for you, because any of the medications that the doctors prescribe are going to have potential side effects, and some of these do as well. In patients with inadequate ventricular rate control, no matter how much medication, if they're on a calcium channel blocker, they're on DIG, they're on a beta blocker, they're doing everything and your heart rate's still 140, 150, then sometimes we send you back to that electrician, and he goes up and not only looks at the heart again, but he'll come back and zap that AV node. So that AV node doesn't collect any information from the atrium anymore. And then he'll have to put a pacemaker in. But that's sometimes better than having a heart rate of 140, 150 that you can't control. That's rare, but we do have options. Here in medicine, you always have to have the best option possible or best treatment plan, because there are people that are outside the normal. Most people will just get medicine. Some people need more intense therapy. Anticoagulation, again, the cornerstone of treatment for atrial fibrillation to prevent strokes. And this is, when I say strokes, the thromboembolism means a blood clot going anywhere in the body. Again, most of the time and most deleterious area is the head or the brain, and that's the one that we want to try and prevent the most. The risk of thromboembolism or blood clots going to the brain increases, especially if you've been in it for more than 48 hours. So if you've been in it for more than 48 hours, you really want to be on anticoagulation prior to any attempts to cardiovert or get you back into a normal rhythm. Because even if you go back into a normal rhythm on your own, you can still throw little blood clots if you don't have blood thinners on board. So that's the reason a lot of people are put on the newer anticoagulants, or that's why we put people in the hospital in order to prevent blood clots going to the brain. You can start warfarin at the same time you're starting the heparin, and the goal for warfarin is a INR or an international ratio of 2.0 to 3.0. For other treatments, for valves, et cetera, it's 2.5 to 3.5. But if you have a valve and atrial fibrillation, you go with the higher treatment dose, treating the valve first rather than the atrial fibrillation. But it is the same medication. Just with atrial fibrillation, we don't want the bleeding risk as high, and we want that a little lower. So this is what the doctor has to go through in his brain. I know this slide's a little busy, but this is what the doctor has to go through in his brain every time someone comes in with a new diagnosis of atrial fibrillation. Is he stable? Which way do you go? Do you shock him? Do you not shock him? Do you anticoagulate him for 3 to 4 weeks before you decide to treat him? Or is he not a candidate for anticoagulation? Do you go through the warfarin cycle? Do you do a TEE, which is a small tube about the size of my little finger? You put it down the esophagus, you look at the heart real close, and if there's no blood clots in the heart, then you can shock that person right away and get them out of the atrial fibrillation. That's an alternative. So this is going through the doctor's mind every time that he sees a new onset of atrial fibrillation. So if you don't always get the same pattern as your neighbor, you might not have the same disease. You may have the same disease, but not the same presentation. So don't be discouraged that you're not having the same thing done to you that your neighbor had when they went into atrial fibrillation. So, long-term management, of course, reducing the risk of stroke and weighing the risk of bleeding. The higher risk you are for stroke from atrial fibrillation, typically the higher risk you are from bleeding from the anticoagulation. The Has Bled study, which is an excellent study that shows people with high risk of blood clots also have high risk of bleeding. Typically, they're more elderly. Typically, they have other problems. And typically, it's a balancing act. And that's what, a lot of what medicine is a balancing act of, can we make the person better without making them sick or worse? So, younger patients, a lot of times we try and keep them into a normal sinus rhythm so they can be active, so they can run, so they can be, out on the playing field. In the older people with already canes and sticks and they already have walkers, they're not going to be as active. Sometimes we just go for rate control and anticoagulation. In both of them, we want anticoagulation, though. And anticoagulation, again, is to reduce the risk of thromboembolism. And we've talked about the INR of being between 2.0 and 3.0. The biggest problem with all the anticoagulation is bleeding. And this is why you see so many lawyers on the TV saying this is bad drug A, this is bad drug B, this is bad drug C. Because the more you use anticoagulation, the bigger the bleeding risk is. The higher your risk for a stroke is, the higher your risk for a bleed is. So no drug is perfect. People are going to have bleeds with these drugs. So be aware. Factors that increase bleeding, again, we talked about. Same things that increase the risk of clotting. So age, high blood pressure, etc. The newer ones, and these are the 4 new anticoagulants called novel anticoagulants, NOACs, NOAC, new oral anticoagulants, or now it's called DOACs because they've been around for a while. So it's not new anymore. They're calling them oral anticoagulants, and they can be used as an alternative to warfarin. And they're rapid acting, they act immediately, and the unfortunate part is warfarin does have an antidote, although it's difficult to get and quite long-term to get it in a lot of pharmacies or into the hospital, even in motor vehicle accident cases where you need to reverse the Coumadin right away. The newer anticoagulants, only one of them has a reversal agent, and it's available. The others do not. However, their half-life, in other words, the time of activity in the body, is shorter. So if you can just keep the person alive for 4 hours, a lot of times the anticoagulant's already out of the body and you're back down to normal. So it's not a perfect drug. None of them are. The other thing is you have to be careful with kidney problems in some of these newer drugs. They are excreted out of the body through the kidneys. So in people with kidney failure, you do have to reduce the dose. Or if they have bleeding on the higher doses, then you sometimes do have to reduce the dose of the medication so that your risk of bleeding is less. Again, risk to benefit ratio. Rate control, again, AV nodal blocking agents. We talked about the beta blockers, the calcium channel blockers, digoxin. We used to try to get them down below 80 at rest. Now we're trying to get them down below 110 at rest, and basically symptom-free. We want people to feel good. Rhythm control, again, frequently in the younger persons with atrial fibrillation. Now, atrial fibrillation can happen at any age. One of my roommates in medical school went into atrial fibrillation. He was a swimmer and a diver, and he held his breath underwater a lot. He developed atrial fibrillation. I've seen it in all age groups, 20 and up. I've actually seen it in younger kids, but they normally have congenital heart disease or they're stitched back wrong. when they had their hearts fixed. So, dodronone is similar to what we call amiodarone. I don't know if you guys have heard the rhythm or the rhythm control medications. Every rhythm control medication can have a pro-arrhythmic effect, so you and your doctor have to really talk about using any medication, and specifically the medication for you, depending on your heart size, your heart strength, the size of the atrium, what is going to be the best one for you. Are you in heart failure or are you not in heart failure? Flecainide and dodronone is one of the relatively newer ones. Flecainide is an older one. Those are used principally to keep people out of atrial fibrillation. Again, typically the younger person that is still active in sports. Dodronone should not be used in people with heart failure. Flecainide should not be used in people with abnormal hearts. So that's why you and your doctor and an echocardiogram have to be done in order for you to get the right medication for you. And then catheter ablation. That's my friend Dr. Berry, or we have a couple down in South Bend as well, where they go up with a pacemaker wire. They go up into the area of the heart. They find those pulmonary veins. They do that zapping that they do, and they fix the problem with the atrial fibrillation. It frequently is a permanent fix. Is it always a permanent fix? No. Sometimes about 5% of it, people will grow back the area that they zapped. So the zapping is just like a scar, and sometimes you get growth back of the little wavelets, and you can have more atrial fibrillation even after an ablation. So even though you've had an ablation, it's usually a cure, but not always. Catheter ablation needs to have anticoagulation for 1 to 3 months afterwards, so you cannot do catheter ablation if you're having a contraindication to Coumadin or warfarin or one of the anticoagulants. So, okay. So that really concludes the causes of atrial fibrillation, the reasons we get it, how to treat it, how do we diagnose it, and how do we manage it long term.